Malignancies like colon cancer.
Yeah, so malignancies. The malignancies like colon cancer. Mm. But again,
Hyperthyroidism.
yeah, so you could also have endocrine conditions like hyperthyroidism. Hyperthyroidism. Aside hyperthyroidism, which other endocrine condition can do diarrhea?
Gastroparesis.
Which one?
Diabetic gastroparesis.
Diabetes can do diarrhea by when you talk about gastroparesis, it does constipation. So we have diabetic diarrhea. So there's diabetic diarrhea. But gastroparesis typically will do constipation. What again? So even on the HIV, you could also have opportunistic infections. And some of the common opportunistic infection implicated in HIV diarrhea. Who can tell me one common opportunistic infection implicated in diarrhea in HIV?
Cryptosporidiosis.
TB.
Yeah, so cryptosporidiosis. Cryptosporidiosis can also do chronic diarrhea. And even amoebiasis. Remember we said Entamoeba histolytica can cause acute diarrhea. It could also do chronic diarrhea. It could also do chronic diarrhea as well. All right. So these are some of the common causes of acute and chronic diarrhea. So whenever you are trying to treat or manage someone with diarrhea, find out the duration. If it's less than 14 days, think of acute infectious pathogen, drug-induced causes, and all that. If it's more than 14 days, then you are thinking about chronic condition. Patient may be diabetic, may be having hyperthyroidism, may be immunosuppressed, a lot of conditions, IBD, IBS. So we'd have to do a workup to find out what is actually causing the chronic diarrhea. All right. So now let's cue our attention to the clinical manifestations. So whenever someone has diarrhea, what are some of the clinical manifestations or the signs and symptoms you expect to see when you have diarrhea?
If it's bacterial diarrhea, it mostly comes with fever, and there could also be blood and mucus in their stool.
Yeah. So you could have blood and mucus in stool. You could also have fever. What again?
Cramps.
What again?
Abdominal cramps.
Yeah, so you can have abdominal cramps or pain. Mm. That's also one of the typical presentation of diarrhea. Any other?
There will be signs of dehydration, such as sunken eyes, reduced skin tegel.
Yeah, so dehydration is one of the common complications associated with diarrhea. So whenever someone presents with diarrhea, you also want to look for signs of dehydration. It could be that it's been happening and the person didn't take any medication, so they become dehydrated. For that matter, in your management, you consider rehydration therapy. So signs of dehydration like sunken eyes. What again, in terms of the dehydration signs, what are some of them?
Dry skin.
Yeah, so the skin will also be dry, Not again.
Dry mucous membranes, like the
Yeah, so
mouth.
dry mucous membranes. So the mouth will be dry, the lips will be dry, the tongue will be dry, and even when patient tries to cry, tears will not be flowing. You have reduced tear production so that eyes become dry. So mucous membranes, the dry eyes, the dry mouth, the dry lips, dry tongue. What again? Signs of
In children, they
dehydration.
become very irritable.
Yeah, so irritability. Mm. Irritability is also one of the signs, especially in children. What again?
Increased thirst, but mostly unable to drink much fluid. That's if the dehydration is severe.
Yeah, so they become thirsty, and depending on the severity of the dehydration, they may be eager to drink or they may feel too weak to drink water. What again? So scale still on the skin.
Weight loss.
Yeah, so weight loss. So you could also have weight loss, reduced skin table. Mm. So the skin table is reduced. You try pinching the skin and you see how long it will take for the skin to return back to its original place. The person is dehydrated. It takes long compared to someone who is not dehydrated. So you tend to have a reduced skin table. Then when you look at the nail beds, we have something called capillary refill time. So capillary refill time, basically, when you look at your nail beds, you realize it's reddish in appearance because you have blood perfusing that area. The moment you pinch down on your nail bed, which we term blanching, the term we use for that is blanching. You are pinching down your nail beds firmly. So when you do that, you realize that instead of the reddish appearance, it becomes white. So that is the area has been blanched. Because when you press down, instead of the reddish appearance, it becomes white. So for capillary refill time, we want to check that time it will take for the blood to return back to its original place after blanching. And the normal is usually 2 to 3 seconds. If it's more than 3 seconds, then the person is dehydrated. But if it's within 2 to 3 seconds, then the person has a normal hydration status. So you can also use the nail beds. You can also check the urine output. So if the urine output is reduced, that could also be a sign of dehydration. What again? Aside dehydration, what again? Signs and symptoms of diarrhea. So you could also have what? Vomiting. Hmm? You could also have vomiting. And definitely you also want to check the consistency of the stool. It will be watery or loose. So watery or loose too. And the patient may also have lethargy. Hmm? Lethargy, they are too weak and all that. Loss of energy. So all these are signs and symptoms you look out for in someone with diarrhea. Now let's move on to talk about the various types of diarrhea based on the pathophysiology. So we have clinical types of diarrhea. And the pathophysiology differs. What actually happens differ for the various types of diarrhea. Let's take them. Let's talk about the types. Basically, there are 5 types of diarrhea. The clinical types, you have 5. Anyone to tell us one?
Osmotic diarrhea.
So we have osmotic diarrhea. What again?
Exudative diarrhea.
Exudative diarrhea. What again?
Secretory diarrhea.
Yeah, so secretory diarrhea. Any other?
Fatty diarrhea.
Yeah, so fatty diarrhea. And the last one?
Inflammatory diarrhea.
Motility diarrhea.
Okay, I think we mentioned inflammation. It's the same as exudative.
Motility
So,
diarrhea.
yeah, so motility diarrhea. So these are the 5 clinical types of diarrhea: osmotic diarrhea, secretory diarrhea, fatty diarrhea, inflammatory or exudative diarrhea, then motility diarrhea. So we take them one after the other and talk about them. So the first one is osmotic diarrhea. So from the name osmotic, this is based on the principle of osmosis. So if you cast your mind back to the osmosis that you learned in maybe JHS or SS, for osmosis to happen, you need 2 concentrations or 2 regions, right? A region of higher water concentration and a region of lower water concentration. Then you need semi-permeable membrane, and the osmosis will continue to happen until equilibrium is established. The same principle applies here. So for osmosis or for osmotic diarrhea to occur, the patient might have ingested an osmotically active substance. So this is usually caused by the presence of an osmotically active substance in the gut. So when you have the presence of osmotically active substance in the gut, it creates an osmotic gradient, thereby drawing water from the plasma to the gut. So when you have that occurring, you tend to have a very watery stool because now a lot of water has been drawn to the gut because of the presence of the osmotically active substance. So there are some people, when they ingest or take certain types of food, very common one is milk. Some people have lactose intolerance. The moment they take milk, they tend to have diarrhea. It's because the milk that they've taken is osmotically active. So it will draw water to the gut and allows the patient to pass watery stool. And basically, that's osmotic diarrhea. So whenever there's presence of osmotically active substance in the gut, creates an osmotic gradient, thereby drawing water to the gut and causing the diarrhea. Typically, for osmotic diarrhea, it resolves with fasting. So if the patient decide to go on a 12 to 24-hour fasting, the diarrhea resolves. So take note. For osmotic diarrhea, we are saying that this usually resolves with a 12 to 24-hour fasting. And it makes sense because the diarrhea is only happening because you took an osmotically active substance. So if you are fasting, it means that you are not going to take these osmotically active substance. For that reason, the diarrhea can resolve. So it resolves with fasting. And I also mentioned the osmotic diarrhea usually presents with watery stool. So it's a watery diarrhea. So you can also check the stool water content. So for osmotic diarrhea, if you should do a 24-hour stool water content, you realize that for osmotic diarrhea, the volume will be less than 1 liter. So the 24 hours stool water content is less than 1 liter. So that is osmotic diarrhea. Any example of things that can cause osmotic diarrhea?
Sugar.
Yeah, so taking sugars, especially these reducing sugars, the sucrose and all that, they are osmotically active. They draw water into the gut, and that can lead to osmotic diarrhea. What again?
Sorbitol.
Yeah, so they are all part of the sugars. So they draw water and cause osmotic diarrhea. Any other? So when I was explaining, I mentioned lactose intolerance. So people with lactose intolerance, whenever they ingest any dairy product, common being milk, they tend to have diarrhea. So such patients usually have osmotic diarrhea. What again? Yeah, so these are the,
Can you come again? What you just said?
yeah, so I said lactose intolerance. When they take dairy products like milk, they tend to have diarrhea. So for such patients, we are saying that the type of diarrhea is osmotic because they ingested osmotically active substances.
Thank
Okay,
you.
yeah. So patients who also take osmotic laxatives. So if you take an osmotic laxative, like any example of osmotic laxative,
Lactulose.
yeah, so lactulose. So osmotic laxatives like lactulose. We usually take lactulose for constipation, but if you don't monitor, that lactulose can also lead to diarrhea. And the type of diarrhea lactulose will lead to is osmotic diarrhea. Because lactulose is non-absorbable, it stays within the gut, draws water to the gut. You get it? So that's how it also causes diarrhea. So it's based on the principle of osmosis. Yes. And some viral infections. Some viral infections also cause osmotic diarrhea. So it's not just presence of osmotically active substance, but some viral infections can also do that. All right. The next one is secretory diarrhea. So for secretory diarrhea, it's very similar to osmotic diarrhea. It also presents with watery stool, just like osmotic diarrhea. We said diarrhea could be watery or loose. Osmotic and secretory usually do watery. So it's like water. Mm. So the diarrhea you're having is like water, watery. So for secretory diarrhea, basically, when food or substances get into the gut, there's supposed to be reabsorption, and the waste products or some electrolytes are also secreted into the gut. So for secretory diarrhea to happen, it's usually because of an imbalance. So when you have increased secretion of substances compared to the reabsorption of substances from the gut. So there's an imbalance. So when you have more secretion of substances, so it could be toxins, it could be water, it could be electrolyte, compared to the reabsorption. You know, water and other essential things in the food or the contents of the gut needs to be reabsorbed. But this is the case. You are having increased secretion of substances to the gut compared to reabsorption from the gut. So when you have that, it can present as secretory diarrhea. So secretory diarrhea. So that's the underlying pathophysiology. You are having impaired fluid and ion transport such that the secretion is exceeding the absorption. And we are also saying this presents as watery diarrhea. The difference between secretory and osmotic diarrhea is that for secretory diarrhea, it does not resolve with fasting. We said osmotic diarrhea usually resolves when you decide to fast for 12 to 24 hours. But for secretory diarrhea, the diarrhea will still persist if you decide to fast. So that is how you can differentiate between secretory and osmotic diarrhea. And the other thing is, when you check the 24-hour stool water content for secretory diarrhea is usually more than 1 liter. So the 24-hour stool water content is more than 1 liter for secretory diarrhea, whereas it's less than 1 liter for osmotic diarrhea. So that is also another difference. And the third one is based on how they occur. Osmotic presence of osmotically active substances, whereas secretory, they are having impaired fluid and ion transport across the GI wall such that secretion is exceeding the absorption. Are you okay? All right, so let's look at some examples of secretory diarrhea. Any example of something that can cause secretory diarrhea? So when you're thinking about secretory diarrhea, think of organisms that can secrete toxins, that can cause the release of toxins. Typically, these ones tend to do secretory diarrhea because they are having a lot of secretion of toxins compared to reabsorption of essential nutrients and water. Any ideas of causes of secretory diarrhea? So one common example is cholera. So cholera, the Vibrio cholera, causes secretory diarrhea. And the Vibrio cholera is able to secrete toxins. If you've seen a typical case of someone with cholera, you realize that the diarrhea is usually explosive. So it's usually explosive. So when they sit on the water closet and they are having cholera, the stool can explode and realize it's scattered everywhere. So that is typical presentation of cholera. So it's a watery stool and is explosive. So that's one of the things to look out for. Aside that, you could also have Shigella. So Shigella can also cause the release of toxins. And that can also do secretory diarrhea. So these are common examples. So Vibrio cholera and Shigella, these do secretory diarrhea. And even E. coli. So E. coli too can sometimes do the toxigenic E. coli. So we have E. coli, which is not toxin producing, but we have toxigenic E. coli that can also do secretory diarrhea. All right, the next one is the inflammatory diarrhea. So inflammatory diarrhea. The other name for inflammatory diarrhea is exudative diarrhea. Exudative diarrhea. So basically what happens from the name, the cause of this diarrhea is an underlying inflammation. So the cause is an underlying what? Inflammation. So you have inflammation that destroys the integrity of the GI wall. So when you have inflammation destroying the integrity of the GI wall, you can have diarrhea. And this type of diarrhea is known as inflammatory diarrhea. So because there's destruction of the integrity of the GI wall, you may have exudates seeping into the stool. You may have blood in stool. You may have mucus in stool. So the typical presentation is the patient will complain of blood in stool or mucus in stool. This is because there's an inflammation destroying the integrity of the GI lining, for which reason
Sir,
we are
can you please
having
repeat
exudate.
what you just said? The network was unstable.
So I'm saying inflammatory diarrhea is caused by inflammation that destroys the integrity of the GI wall. So usually the stool is associated with blood and mucus because there's destruction of the integrity. You have exudates seeping in. You also have blood, mucus. So the patient complains of blood in stool, mucus in stool. Whenever you have that, it's an inflammatory diarrhea or exudative diarrhea. And what are some of the conditions that can cause inflammatory or exudative diarrhea? Any examples?
IBD.
Inflammatory bowel syndrome.
So IBD, inflammatory bowel disease. Inflammatory bowel disease, ulcerative colitis, and Crohn's disease both can do inflammatory diarrhea. Can cause blood in stool, can cause mucus in stool. So that's one common example. Aside that, Shigella can also do inflammatory diarrhea as well. So shigellosis, you can have blood and mucus in stool. Because Shigella is very invasive, it can destroy the integrity of the GI lining, causing blood and also mucus in stool. All right, the next one is fatty diarrhea. Fatty diarrhea. So for fatty diarrhea, from the name, basically diarrhea associated with fat in stool. So when you have any diarrhea, which is characterized by a lot of fat in stool, then we are talking about fatty diarrhea. So basically, in terms of the presentation, the patients can come in complaining of difficult to flush stool. They've realized that whenever they visit the washroom, after everything, whenever they try flushing, you realize that the stool is very difficult to flush. It's because you're having a lot of fat And because when you check the water closet, what you have there is water. You know, water and fat are not easily mixed. Mhm. So that water in there is difficult to flush it becomes difficult to flush the fatty stool the person just excreted. So because of that, they tend to use more water to be able to flush the stool. So difficult to flush stool. And the stool is also foul smelling. Unlike the usual smell, this is more foul smelling. And what are some of the examples or conditions that could present as fatty diarrhea? Any example? All right. So for patients who are on weight losing medications like Orlistat, so you have this medication known as Orlistat, and Orlistat helps you to reduce weight. And how it does that is because Orlistat is able to inhibit the enzyme known as lipase. So in the gut, there's this enzyme known as lipase. And the role of the lipase is it helps in the digestion of fat in food. So whenever you eat any meal that contains fat, what happens is bile is produced and bile emulsifies the fat. Once the fat is emulsified into smaller droplets, we have the lipase enzyme breaking down the fat into fatty acids and glycerol. So the lipase is responsible for the digestion of fat. So when you take Orlistat inhibits the lipase enzyme. And if you inhibit the lipase enzyme, that means all the fat the patient takes in their meal, that fat wouldn't be digested. For that matter, it wouldn't also be absorbed because the absorbable form is the fatty acids and glycerol. So you don't have lipase to break down the fat into fatty acids and glycerol. So all the fat you take in your meals wouldn't be absorbed. The body relies on already accumulated fat and tries to burn those fats for energy. So that's how Orlistat works. So for that reason, all the fat that you take in your meals wouldn't be absorbed and come out through your feces. So such patients tend to have fatty stool. And the technical term for that is steatorrhea. So if you hear of steatorrhea, it means fatty stool, steatorrhea. Another example is when you are infected with gardiasis. So the Gardia lamblia, which is one of the protozoal causes of diarrhea. Gardia lamblia typically does fatty stool, so the stool appears yellowish because of the fat in there and it's foul smelling too. So that is another example of fatty diarrhea. The last one, motility diarrhea. Motility diarrhea. So for motility diarrhea, basically the normal person, when you take food, it moves through the intestine. And the intestine tries to propel food via the peristaltic mechanism. So you have the contractions and relaxations of the intestine, and that helps to propel food along the intestine. So that's peristalsis. For motility diarrhea, the issue is because of increased or excessive peristaltic movement. So the normal thing is you should have peristaltic movement to propel food along the intestine. However, if the peristaltic movement is increased, so it becomes excessive compared to the normal, patient will have diarrhea. If it becomes lesser than normal, patient will have um, constipation. So for motility diarrhea, the issue is because of excessive peristaltic movement, and that propels food at a very fast rate. So one of the presentation they'll tell you is, oh, when they take food right away, you realize that they want to visit the washroom. The moment they eat, they want to go to the washroom because the peristaltic movement is very fast. It moves along the gut at a very fast rate. So right after taking the food, they feel like going to the washroom. So that is motility diarrhea. And any example you could think of that can cause motility diarrhea.
So the motility diarrhea basically drugs that can increase the GI motility. So metoclopramide and domperidone, and also erythromycin can also do that.
That's true. So any drug that can increase motility of the gut can cause motility diarrhea. So the prokinetics like domperidone, metoclopramide tend to do motility diarrhea. Then there is this antibiotic, erythromycin. Erythromycin, is a macrolide or macrolide antibiotic. But this erythromycin can also cause motility diarrhea. It's able to activate a certain receptor in the gut known as motilin receptor. So you have this receptor in the gut known as motilin. So activation of the motilin receptor in the gut can increase peristaltic movement and lead to diarrhea from erythromycin therapy. So that is also one of the causes of motility diarrhea. Any other? So patients with irritable bowel syndrome. So we said irritable bowel syndrome is not really a disease, but a functional state, and is regarded as a functional state because the normal thing is everyone should have peristaltic movement. So for irritable bowel syndrome, we say there's diarrhea alternating with constipation. So what happens is when you have increased peristaltic movement, can lead to the diarrhea manifestation. When you have reduced peristaltic movement, it leads to the constipation. So that's what happens in irritable bowel syndrome. It's because of the peristaltic movement. Increased peristaltic movement leads to diarrhea. Reduced peristaltic movement leads to what? Constipation. So one of the causes of motility diarrhea is irritable bowel syndrome leading to diarrhea. Okay, so these are the 5 clinical subtypes of diarrhea. Do you have any questions? Are you okay?
Yes, sir.
Okay. Now let's move on to talk about how to clinically diagnose diarrhea at the community setting. So at a community setting, you may not have the luxury of doing labs to confirm the type of diarrhea. But as much as possible, whenever someone walks in and talks about they having diarrhea, your history taking is very important. So the history taking can give you an idea of the possible cause of the diarrhea. So usually we want to find out certain questions from the patient. So if someone presents with diarrhea and you ask, do you have fever? They tell you they have fever. You ask them again, do you have abdominal pain? They tell you there is presence of abdominal pain. You ask about blood or mucus in stool, and they tell you there's blood and mucus in stool. You ask about vomiting, they tell you there's vomiting. Which of the infectious pathogen
So,
would you think of?
so please, before you continue, I have a question that just came to mind. So, for the gay community like this, where they have fecal incontinence, how will we classify that type of diarrhea?
So fecal incontinence cannot be classified as diarrhea. So the issue is they are not able to hold the stool. Ideally, you should have some sphincter tone to hold the stool. But people with fecal incontinence, the issue is not because they have watery or loose stools or something, but they are not able to hold the stool. So that is a different issue, but it's not classified as diarrhea.
All right, thanks.
Okay. So I was talking about someone presenting with diarrhea. You find out whether there's fever. They tell you there's fever. You ask about vomiting. There's vomiting. You ask about whether there's blood and mucus in stool. They tell you there's blood. About abdominal pain. They tell you there's abdominal pain. Which of the infectious pathogen would you think about? Which of the infectious pathogen?
Cholera.
Bacteria.
So basically bacteria. So that is a typical presentation of a bacterial cause. Because you are the community setting, you don't have luxury of going to do the stool culture to confirm whatever is actually happening. But generally, there are some key pointers to bacterial causes. Bacterial causes typically will do fever. They will do abdominal pain. They may also do blood and mucus in stool. So whenever you have that, you think of what? Bacterial causes. All right. What about someone with diarrhea with low-grade fever? And there's also vomiting, but absence of blood and mucus in stool. Which one would you think about?
Viral.
Yeah, so viral causes tend to do low-grade fever. So you may have diarrhea. You ask them whether there's blood and mucus. They tell you there's none. You ask them whether there's vomiting. They may be vomiting or they may not be vomiting. And ask about fever. Typically, they have a mild fever, so low-grade fever. So that is how you classify or think about viral causes. They typically wouldn't do blood or mucus. The moment you see blood and mucus, think about bacterial causes rather than viral. All right, for another patient who presents with diarrhea and you ask them whether there's fever, they tell you they don't have fever, but there's mucus in stool, there's vomiting. Which of the infectious pathogen would you think about?
Protozoa.
Yeah, so protozoa. So protozoa typically will do diarrhea with the absence of fever, but you have mucus in stool. So that's the difference between protozoa causes and bacteria. Bacteria typically will do fever. Protozoa does, there is normal temperature, there is no fever. But those will do mucus in stool. All right. What about diarrhea alternating with constipation? What would you think about?
So I don't know if it's just me, but there's this background noise like a vibration.
Yeah, I received a call, but I didn't pick. I received a call. All right. So I was asking about diarrhea alternating with constipation.
It's likely to be colon cancer.
Yeah. So it could be malignancy or it could be irritable bowel syndrome. So if you do your investigations, work up, and you don't find any malignancy, then you think about irritable bowel syndrome. Other than that, when you have diarrhea alternating with constipation, think about irritable bowel syndrome, think about malignancies. All right. What about someone having diarrhea? You ask them whether there's vomiting, they tell you there's vomiting. You also want to find out the nature of the stool, and they tell you it appears as rice water. So you know how rice water appears. So they tell you they are having rice water like stool. Which infectious pathogen would you think about?
Cholera.
Cholera.
Yeah, so cholera tend to do diarrhea diarrhea with rice water stool like appearance. So that's the typical presentation of cholera. Usually the stool is watery, is explosive, and it has that rice water appearance. Okay. We could also have another patient presenting with diarrhea. You try to find out household. Are you having any other person having diarrhea? And they tell you, oh, maybe their brother, their sister, they have two other people also having the same issue. What would you think about?
Food poisoning.
Yeah, so possible food poisoning because they are from the same household. So these are usually the workup we do for diarrhea. And this is very essential, especially in the community pharmacy setting, because you may not have the luxury of doing the labs and all that. But based on what they tell you, history, you have some idea, such that if you think it's bacteria, you may want to give some antibiotics. If you think it's viral, you may just stick to hydration, ORS, and all that. If it's protozoa, you may think of giving some anti-protozoa agents like metronidazole and all that. If it's cholera, you may think about tetracycline and all that. So these are very essential um, workup tools you can use in the community setting. However, if you're in the hospital setting, the diagnosis, even though you're in the hospital setting, the first thing is the history taking, just like what we just went through. How is the diarrhea like? Is it watery? Is it loose? Is there blood? Is there mucus? Is there vomiting, abdominal pain? How is it like? So that is the first point of call that you want to take, the history taking. Then you also want to find out in terms of the full blood count is one of the first workup we do for every patient who enters the hospital. You want to do a full blood count. For the full blood count, for someone with an infective diarrhea, if the WBC is high, we want to check the WBC differentials because the WBC differentials can give you an idea of the possible cause. So if neutrophils are high, then you think about bacterial causes. If lymphocytes are high, then what would you think about? If lymphocytes are high,
Viral.
yeah, viral. So neutrophils, think about bacterial causes. Lymphocytes, you think about viral causes. If eosinophils are high, Then you think about parasitic causes. So eosinophils, think about parasitic. It could be worms, it could be the protozoa. All these are parasites. So they tend to do eosinophilia. So that is a very important workup tool you can use, the food. And you also want to check for other indices. Is there anemia and all that? So that you correct whether there's anemia, you would also want to correct. You could also do the stool culture. You realize the history, it can tell you that maybe you are dealing with bacteria, you are dealing with protozoa, but it's not telling you the exact bacteria. Is it Salmonella? Is it Shigella? Is it Campylobacter? You need stool culture. So if you really want to confirm the exact organism, you can do stool culture and sensitivity. So that can also be done. But before the stool culture, usually one of the first thing they do is the stool RE. The stool RE, which is routine examination. The stool RE. Basically, when they do the stool RE, some of the things they check for is the presence of cysts. So for organisms that are able to produce cysts, like Entamoeba histolytica, you find the cyst form in the stool. So you check for the presence of cyst. They also check for the presence of ova. Ova, we are referring to the eggs. So especially worms. Worms tend to do a lot of eggs, so ova. Then you could also see the pathogen itself. So the stool microscopy, they can check for the cyst, the eggs, which is the ova, and the pathogen itself. So that is also essential. Then if you are thinking of malignancies, you may also want to do colonoscopy to check for the presence of possible colon cancer and all that. Then if it's inflammatory diarrhea you're thinking about because of the blood and mucus in stool, you can check for ESR and C-reactive protein. These are markers of inflammation. So when ESR or C-reactive protein is high, it can tell you there's an ongoing inflammation. You could also check for procalcitonin. Procalcitonin is also a marker for sepsis. So you can also do procalcitonin test. That can give you an idea of possible sepsis. So that can also be done. And also for patients you are thinking of having inflammatory diarrhea, you could also do what we call the fecal calprotectin test. So we have a test known as fecal calprotectin. So for fecal calprotectin test, this calprotectin is basically a protein that is released whenever you have inflammation in the gut. So if you have any inflammation occurring, there's a migration of white blood cells. So the presence of neutrophils in the gut cause the release of calprotectin. And this calprotectin can give you an idea of possible ongoing inflammation. So it can be used for patients you are thinking of IBD. So if you are thinking they have IBD, fecal calprotectin can be used. We also have fecal lactoferrin. So fecal lactoferrin can also be done. It also is also just like the calprotectin test. It's also released whenever there's inflammation. So he said whenever there's inflammation, there's a migration of white blood cells to the gut. So the presence of white blood cells causes the release of proteins. And we said one of the proteins is calprotectin, which is released whenever there is what? Inflammation. And this is released by the neutrophils. The lactoferrin is also released by the leukocytes. So whenever you have leukocytes, the leukocytes are able to release lactoferrin. So that can also be used as a marker of an ongoing inflammation. So these are more specific tests for IBD and all that. So that can also be done. Other than that, most cases of diarrhea, based on the history taken, you have an idea of what to give in the management. Any question?
Is which white blood cell did you say releases the lactoferrin?
Leukocytes. So calprotectin is neutrophils. Leukocytes release lactoferrin. Any other questions? All right, so if there are no other questions, we'll end here. Hopefully the next time we meet, we'll talk about the management. And if there's time, we would do some questions on diarrhea. And that'll be the end of diarrhea.
So I have a question. The ESR in the C-reactive protein that is checking for inflammation, will it be can it be related to diarrhea caused by bacteria, or it will be related strictly to inflammatory diarrhea?
Yeah, so basically anything that causes inflammation can cause the increase in ESR and C-reactive protein. But aside that, C-reactive protein can also be elevated whenever there is infection. So it gives you an idea of possible infection or possible inflammation.
Thank you.
Okay, any other question? Okay, so if there are no other questions, we'll end here. Hopefully next week we'll continue. Have a good evening.
You too.
Have a good evening. Bye.
Thank you, sir.